So, aplastic anemia. Let's talk about aplastic anemia. So, aplastic anemia is most commonly due to a toxic effect or autoimmune response causing apoptosis of pluripotent stem cells, pancytopenia. Bone marrow biopsy reveals hypocellularity with an abundance of fat cells. So, there's a dry tap. Aplastic anemia means the bone marrow is infiltrated by any cells, for example, a tumor cell due to a toxic effect, and there are several drugs that cause aplastic anemia like chloramphenicol, or any autoimmune response that causes pluripotent stem cells inside the bone marrow to be deformed, which leads to decrease in all cell lineages. So bone marrow biopsy reveals hypocellularity with evidence of fat cells. So it makes sense. Now let's talk about phenotypically. So given phenotypically normal parents, the probability that a female sibling of a male affected by an X-linked recessive disease will give birth to an affected child is 1 by 8. So given phenotypically normal parents, so if there are normal parents, the probability that the female sibling of a male, so male giving rise to a daughter, affected by X-linked recessive disease. So X-linked recessive disease in a male. So if a male has X-linked recessive disease, then the chances of his daughter carrying the X-linked disease is very slim, because the another X, because Syrian, the daughter receives a normal X chromosome from her mother, and therefore the chance of having X-linked recessive disease is very slim, and that is till 1 by 8. Now next point is about deficiency of vitamin B12. So deficiency of vitamin B12 is associated with megaloblastic anemia and neurological dysfunction, whereas B9 deficiency is associated with megaloblastic anemia alone. Moderate improvement in the hemoglobin level often occurs when a deficiency of vitamin B12 is treated with vitamin B9. So treatment of B12 deficiency with B9 alone can worsen neurological dysfunction. It was already discussed before. Now let's talk about the next point. Hypochromic microcytic anemia is most commonly due to iron deficiency, blood loss, especially occult loss from the GI tract. Also, the menorrhagia that occurs in female must be ruled out in a patient with IDA. So, in a patient with IDA, occult blood loss from GI tract must be ruled out. Next point, anemia in a woman of childbearing age is most commonly caused by iron deficiency secondary to menstrual blood loss. So anemia, so if there is anemia in a woman of a childbearing age, if or a woman has potential to be pregnant, it occurs because of iron deficiency secondary to menstrual blood loss. I had already discussed it before. Iron deficiency is associated with decreased serum ferritin. So the storage form of iron is low, and because the iron is low, there is the iron binding protein, that is TIBC, increased TIBC, microcytic hypochromic red blood cells. Increased bone marrow EPO, so erythropoietin. So even if there is increased bone marrow erythropoietin, it results in accelerated release of immature RBCs. So how does reticulocytes increase in blood after hemolytic destruction of the RBC? So when the RBC are decreased, then there is greater production of EPO by the kidneys. EPO acts on bone marrow and results in faster, earlier release of all the cell lines that are present in the bone marrow. Reticulocytes are some of the preliminary form of the mature erythrocytes or immature RBCs, which are released in the blood. Therefore, reticulocytes contain blue-based cytoplasm and reticular precipitates of residual ribosomal RNA. So reticulocytes contain there are some bluish kind of cytoplasm and bluish kind of cytoplasm. So the cytoplasm is very blue. So the cytoplasm is blue, and there is some reticulin-like structure which is made up of ribosomal RNA. rRNA is present. So rRNA is present. All right. So next point, most chemical carcinogens enter the body in an inactive state, that is procarcinogens. These procarcinogens are converted into active metabolites by the CYP450 oxidase system. So liver metabolism activates those prodrugs or procarcinogens into carcinogens. Individual susceptibility to chemical carcinogens depend on the activity of this P450 enzyme, which is genetically determined. So P450, if there is more activity or higher activity of P450 enzymes, then it is more carcinogenic than in those individuals where P450 cytochrome oxidase system is less active. Next point, ALL. So acute lymphoblastic leukemia is the most common malignancy of childhood. So ALL is most common in childhood. The BALL is responsible for approximately 70 to 80% of cases of ALL, whereas TAL accounts for 15 to 17%, 15 to 7%, 70 to 80%. So BAL is more common than TAL, and T cell ALL often presents as a mediastinal mass. So T cell ALL, thymic cell ALL, is a T cell ALL, so which is present in T cells mature in thymus. So T cell ALL often present at mediastinal mass. So thymus is present in the mediastinum, so it forms or it presents as a mediastinal mass. So there's a lung on the side, esophagus on the side, cerebrovena caval artery on the side. So all these three symptoms, respiratory symptom, dysphagia, or SVC syndrome, all of three can occur, or all slash some of these three can occur in a patient with TAL. Hemorrhagic cystitis. So hemorrhagic cystitis is due to a drug called cyclophosphamide. So during therapy with cyclophosphamide or ifosfamide, so ifosfamide also contains phosphamide. So something with phosphamide is called a urinary excretion of the toxic metabolite acrolein. So acrolein is something that is the metabolic product or byproduct of this drug, cyclophosphamide or ifosfamide, and acrolein, which is produced by the metabolism of these drugs, come into the urine and turn it red. It can be prevented by aggressive hydration. So to prevent it, aggressive hydration is mandatory. Bladder irrigation and administration of mesna. So bladder irrigation and mesna administration. Mesna is actually a sulfhydryl compound that binds acrolein in the urine. So mesna is a sulfhydryl compound that binds to acrolein present in the urine, thus eliminating any red color in the urine. Now, next point is about leucovorin, which is a folinic acid. Leucovorin is actually a brand name. Folinic acid can reverse the toxic effect of methotrexate in a non-cancer cells in GI mucosa and bone marrow if administered at the appropriate time. So, folinic acid is given to reverse the toxicity of methotrexate. So, methotrexate inhibits dihydrofolate reductase enzyme, which is also responsible for the formation of folic acid inside the body. So folic acid is decreased to a greater degree when methotrexate is taken. Therefore, the synthetic derivative of folic acid, which is folinic acid, must be given in patients with taking methotrexate, and especially in the non-cancer cells in the GI mucosa. So non-cancerous cells in GI mucosa and bone marrow. So GI mucosal cancers and non-cancer cells in the GI mucosa as well in the bone marrow. Mostly, leucovorin should be given in those cases, and leucovorin is also the reduced form of vitamin B9 that does not require the action of DHFR. So dihydrofolate reductase reduces the folic acid, so dihydrofolate, so tetrahydrofolic acid to dihydrofolic acid. So the reduced form is the folic acid. Therefore, the reductive enzyme, which is degraded by methotrexate, is bypassed. So the human MDR1 gene codes for P glycoprotein. So there is a gene called MDR1 gene. So MDR1 gene codes for a glycoprotein called P glycoprotein. It is a transmembrane ATP dependent efflux protein pump that has broad specificity. So let's say this is cell membrane. So cell membrane has a transmembrane glycoprotein, which is P glycoprotein. So this is P glycoprotein, which is coded by MDR1. So multi-dog resistance 1 gene codes for P glycoprotein, which is transmembrane ATP dependent efflux protein. So it causes the efflux of something from inside the cell, and that is a broad specificity for hydrophobic compounds. So it has a specificity for this protein. P protein has a specificity for hydrophobic compounds. So hydrophobic compounds. So not philic but hydrophobic compounds. This protein can both decrease the influx of drugs into the cytosol. So if any drug enters the cell, then it can excrete it, right, efflux it outside, therefore reducing the total concentration inside the cell, and can efflux from the cytosol, thereby preventing the action of chemotherapy agents. So chemotherapeutic agents, the concentration of chemotherapy agent in a normal cell is prevented. So to prevent the increased concentration of chemotherapeutic agents inside the normal cell, they have something called P glycoprotein, which is coded by MDR1. So drug resistant to it makes drug resistant to a cell. So there is some efflux mechanism that plays in a cell surface, that's present in the cell surface, which causes efflux of the drugs taken inside the cell, thereby preventing the action of chemotherapeutic agents. Now, vitamin B12 is obtained through the diet solely from animal sources, which places strict vegans at risk for dietary deficiency. This deficiency takes years to develop due to the large hepatic B12 reserve and presence with megaloblastic anemia and potential 80% neurological deficits. So, yeah, this is a very common fact. The next point is the major chronic path changes in the spleen of patients with SCA. So the major chronic pathological change in the spleens of patients with SCA results from repetitive splenic infarction caused by splenic microvessel occlusion. So there is a repetitive occlusion of splenic vessels by the sickling of the cells that occur in patients with SCA, sickle cell anemia, and therefore fibrosis, brownish discoloration, even through autosplenectomy ultimate result. So there is fibrosis and brownish discoloration and autosplenectomy. There is also a fact discussed earlier. Now, vitamin B9 inhibits synthesis of NAs, so nucleic acid. So, vitamin B9 inhibits synthesis of Na, particularly the formation of D, DTMP. So, formation of DTMP. Vitamin B9 inhibits synthesis of nucleic acids, particularly the formation of DTMP. So, DNA formation is impaired. This leads to defective DNA synthesis. So, DTMP is not formed, therefore, this leads to defective DNA synthesis that characteristically causes increased apoptosis of HPO cells and megaloblastic anemia. Thymidine supplementation bypasses the enzyme and can decrease erythroid cell apoptosis. So thymidine supplementation bypasses this enzyme and can decrease erythroid cells apoptosis.